Hello, my name is Klassen, and I'm going to talk about analgesia in the field. By way of introduction, I'm an emergency medicine physician and EMS and pre-hospital medicine physician in Rochester, Minnesota, and I work with Mayo Clinic and Mayo Clinic Ambulance Service. I'm going to discuss a few topics, starting with the neurobiology and psychology of pain, because I think that these can help us to find alternative routes in order to treat pain, especially in resource-poor areas. I'm going to talk a little bit about challenges in providing analgesia outside the traditional clinical environment, and I'm going to talk about those analgesics that may be presently available in your situation, and then a few alternative and potential future considerations that you might think about when treating your patients. First, a little bit about the neurobiology and psychology of pain. The perception of pain starts, of course, with activation of neurons at the point of the injury, typically in the skin, but anywhere else in the body as well. These are transmitted through fibers through the spinal cord and ultimately to the brain, where they reach the thalamus and then are distributed. Now, some of this is very important to know when it comes to topics like regional or local anesthesia, and these are excellent targets for analgesia, though can be somewhat less practical in a non-traditional clinical environment in order to perform these, although they do make excellent methodologies for treating pain. But the reason I talk about this is because of what happens after that sensory information is distributed by the thalamus. Some of it goes to the sensomotor cortex, where it is perceived directly and mapped out by the homunculus onto the patient's sensation. But it also is distributed to affective and cognitive areas of the brain. And these are really important concepts to remember when talking about our pain and how we treat it. So I would argue that even though we traditionally think of the nervous system in terms of peripheral nerves or even spinal blocks in order to achieve analgesia, the role of pain and how pain plays a role in evolution, specifically triggering things like reflexive withdrawal, avoidance, and learning, this shapes where those signals go to the brain and opens other avenues for treating pain. And so even though we typically focus on the sensory domains when treating pain, we should not overlook the affective or cognitive domains when we're treating pain. Outside the traditional clinical environment, there are a number of considerations that need to be kept front of mind. And these are things that are all familiar, that would be familiar to all of you who work outside of a traditional hospital setting already. Things like limited resources. For example, if you're going to bring care to the patient or you're going to set up an area to provide care to a patient outside of a traditional environment, you need to be mobile. And so you can only really use what you can carry with you. There's limitations in personnel that are more acute outside the hospital than they are in the hospital in most situations. And then there's limited capabilities. It may not be practical, for example, to obtain intravenous access or to obtain other more advanced imaging or target regional nerve blocks in the out-of-hospital environment. There may be limitations in how you can monitor a patient who's out in an austere environment and you want to administer things like opioids. You have to be careful about your dosing because you may not be able to monitor for hypoventilation as easily. You also need to consider the need or potential need to evacuate a patient, and so that patient may even need to self-evacuate depending on the situation. And then there's always the consideration of extended field time and the amount of time that you might end up spending with the patient, which redoubles the concerns about things like resources. If I give an appropriate dose for the hospital in this austere environment, I might run out too soon, and so it might make more sense to limit and ration doses of analgesics in order to stretch them longer. Now, all of these considerations exist even outside of a combat zone, but in a combat zone, there are additional concerns that need to be kept front of mind. And these are things like the fact that rescuers' tasks may conflict with security tasks. Helping a patient who's injured in a combat zone may take somebody out of the fight that needs to be in the fight, and it may mean that the rescuer is only available for a brief period of time. There's a much higher likelihood of resource-need mismatch, which is sometimes how people define mass casualty incidents. These are far more likely in a combat zone. And then, of course, there are hazards from patient impairments. If I administer medication to an armed combatant who then has poor judgment, it may be the case that they are unsafe with that firearm. And then that patient may also need to participate in their own defense, and so medications that are affect judgment, coordination, or other tasks can be dangerous to administer in a combat zone in some cases. When we talk about strategies or routes of administration of medications, we can put them into lots of different categories, and these all have different amounts of value and practicality in an austere environment. The non-pharmacologic strategies, I'll talk more about some of these a little bit later, but these can be things like reducing fractures or dislocation, covering wounds, maybe others that I'll talk about later. There's over-the-counter medications that might be readily available, and these are things like non-steroidal anti-inflammatory drugs, acetaminophen or paracetamol, or even other non-traditional things. You might even consider a rectal route of administration for some of these over-the-counter medications. There's oral prescription type medications such as opioids or benzodiazepines. These classes can also be used intramuscular or intranasal and have different pharmacology profiles and pharmacokinetic profiles depending on their how they're used and which medications are used. And then, of course, there's intraosseous or intravenous administration. Finally, there are regional or local anesthesia that can be performed if local anesthetics are available to the rescuer or care provider, and these can be a very good match for extended field care if the resources are available. But some of them are challenging to do or require ultrasound guidance, which can narrow the skill set needed in order to, or I should say, broaden the skill set needed and narrow the available rescuer pool who might be able to administer those medications. Specifically, talking about IV or IO administration of medications, there are some general things to consider. First of all, in terms of dosing and access, it's important to remember when you're dosing these medications, they're often weight-based, and the weight may or may not be known. Vascular access is frequently indicated in trauma, and so vascular access may be a priority for other reasons anyway. And oftentimes IV or IO administration is amenable to bolus dosing, which this is a good choice if you're unable to monitor a patient continuously. You're less likely to inadvertently overdose a patient, and you can titrate your next dose based on your previous dose. Of course, this requires frequent checks with the patient in order to make sure that the medication is not worn off, and in order to make judgment decisions about the next dose to be administered. And contrast this with infusion dosing, which is much more frequently used in places like the intensive care unit because it reduces the amount of provider burden. You can administer that medication and then go care for somebody else. The downside, of course, is it often requires monitoring in order to do so safely. If you can't monitor a patient and you have them on an opioid infusion, then you're very likely to, or you're at risk of overdosing them and leading to apnea. And so monitoring equipment such as we have in the intensive care unit can make this a safe and practical technique, but it comes with risks in an austere environment where monitoring might be less practical. Another thing to consider is administering multiple medications in the same mixed bag. So, for example, this might be administering things like ketamine and fentanyl and midazolam in one bag. This simplifies the administration of multiple infusions, and it can be a practical way when you have limited vascular access, you have limited availability of pumps or drip sets, and it can allow you to use smaller doses of each of the medications in order to achieve the same level of analgesia or sedation. But this does increase the risks because now the complexity is much higher, and the risk of the risk of complications can be higher. So there needs to be some careful consideration when deciding whether or not to use a mixed bag infusion like this, with careful consideration of the doses of the individual medications relative to one another, their concentrations, and then regular monitoring, especially early in the infusion, while ensuring that the dose is titrated to the appropriate effect. Talking a little bit about some of the pharmacologic analgesics that are available. Of course, not all of these will be universally available. I'm going to talk about these in general terms. First of all, opioids and opioid-like medications. Fentanyl and morphine are oftentimes the most readily available, though there are others that you'll find. Things like hydromorphone, for example, is frequently available in my environment, but may or may not be in yours. It's important to know with any of these what the pharmacokinetic properties are. Fentanyl, morphine, hydromorphone, and some of these other fairly pure opioid agonists, they tend to create significant analgesia and be quite effective in their pain relief, but have very different pharmacokinetic properties. Fentanyl being a very fast-acting and short-duration medication, hydromorphone being a very fast-acting but long-duration medication, and morphine being a little bit slower onset, a little bit longer duration, but coming with some more histaminergic effects than the other medications, things like pruritus, itching, or rash being somewhat more common. Then there's medications like tramadol. Tramadol is not a pure medication at all. It strikes at several receptors, which can be an advantage to some degree when hitting multiple receptors, but because it's a little bit less pure, is a little more dangerous in overdose. And so the use of something like tramadol should be done cautiously, especially if contemplating higher doses. Although, as I said, it can be an effective medication. Dexketoprofen is an oral NSAID, or also called ketoprofen. This is a medication that is not readily available in my own practice, but medicines from this class, being NSAIDs, can be quite effective. It's available in several different formulations, either an immediate release or an extended release capsule. Because of its oral administration and regular dosing patterns, it can be an effective medication to use, especially for self-administered analgesia, or for somebody with less severe pain who's able to provide some care for themselves. There's also pediatric dosing there, which is, of course, weight-based dosing. Ketorolac is another medication from this same class, and it's one that I use frequently in my own practice. It's available through multiple different routes of administration, although I typically use IV or IM in my own practice. The dosing for this is 15 milligrams every 6 hours. Higher doses have been used in the past, but there are some studies out there that suggest that there's no additional pain relief for doses higher than 15 milligrams, and so that can be a safer dose to administer. The pediatric dosing there is 0.5 milligrams per kilogram, but the dosing frequency is the same. And again, that's a maximum of 15 milligrams is all that's required typically. Ketamine is a medication that I use with quite some frequency, although S-ketamine is not available to me. As I understand it, it might be available to some of you. It's the pure dextrorotary enantiomer of ketamine, and it's felt to have fewer neuropsychotropic side effects as compared to racemic ketamine, and therefore has a slightly lower dosing than the racemic ketamine. Racemic ketamine being what I typically use. I'm far more familiar with the dosing there. What's really good about ketamine, and also to S-ketamine, though, again with less experience, I can't speak with that with as much experience, is that you can use different dosing levels in order to achieve different objectives. It's a great analgesic at lower doses, so IV or IO, 1/4 to 1/2 milligram per kilogram can achieve excellent analgesia, or intramuscular dosing, which will last a little bit longer but slightly less predictable pharmacokinetics. 1/2 to 1 milligram per kilogram can be effective. But if you need to perform anesthesia, you need to actually dissociate a patient in order to care for them. 1/2 to 2 milligrams per per kilogram IV or IO, or 4 to 6 milligrams per kilogram of intramuscular can be effective at achieving complete dissociation and enough to do even very painful or even invasive procedures. Ketamine is not associated on its own with respiratory depression, but there is some evidence, and I have some experience to suggest that when used in combination with other medications, there can be hypoventilation. I suspect this is because some of those other medications can have a dose and stimulation-dependent effect on respiratory depression. And what I mean by that is if you give a high dose of an opioid and you achieve reasonable analgesia, but the patient is still in some pain, and then you dissociate them or you remove some additional pain by using ketamine, it might be the case that that dose of opioid that was already given might become enough to cause respiratory depression, or even potentially hypotension if you remove enough sympathetic surge or stimulation. And so I would be careful when using ketamine in combination with other medications. It can be highly effective because of the synergistic effect, but it also raises the risk of inadvertent overdose. So be cautious when using ketamine in combination with other medications, and whenever using ketamine, always try to monitor your patient as best as you're able. In an emergency department environment, or when you have it available, end tidal monitoring, as well as things like cardiac monitoring, blood pressure monitoring, and pulse oximetry are very wise if you have them available. Although the paramedics that I work with use this fairly frequently outside of the hospital, and it is a very safe medication in my experience. I'm going to talk briefly about some future directions that and medications that you might consider if you can get them, if you can make them available. Although as far as the medication that I'm going to talk about, it's not something I'm able to get. And then I'm going to talk a little bit about some of the alternative approaches to analgesia that you might consider and that might be more effective than you realize, that focus on the cognitive and affective domains of pain. So the medication that I wish I could get is Penthrox, which is methoxyfluorine. It's readily available in Australia and used there fairly widely. It's a volatile anesthetic, and so you might be surprised if you're not familiar with this medication to hear that it's a volatile anesthetic but is used outside of the hospital. It's actually a fairly clever design because the patient can self-administer through the so-called green whistle that Penthrox sells, and the patient can hold it up and breathe through it, and if they get over sedated, then they won't hold it up to them anymore, and they'll breathe off some of the volatile anesthetic and down titrate their level of sedation and pain. They do use it safely and effectively there. It is not approved in the United States by the FDA, and so I don't have it available to me here. There's some talk that it could at some point go through some testing with FDA, and I'm hopeful that that'll happen. It was removed from the market here because of some renal and hepatic effects that were found at very high doses when it was used in the operating theater, and that's why it's no longer available in the United States. But as I said, is used fairly extensively in Australia. Shifting gears a little bit to some cognitive and behavioral approaches to analgesia. This specific list here actually comes from a paper describing strategies for pain management in the pediatric emergency department. In some ways, children are far more sensitive to pain than adults, and I think all of us intuitively appreciate that. But at the same time, they're also a little bit less, in some cases anyway, I find can be a little bit less tied to the fear that goes with a medical procedure. And what I mean by that is if you spend some time coaching and preparing a child for what they're going to experience and addressing any of the fears that they might have, in many children, especially older children and adolescents, you can reduce the amount of discomfort that they experience. And a lot of these techniques can be very effective, and they're strongly recommended in pediatric emergency departments. Their practicality out in an austere environment can vary, and so depending on your environment and how you work with potential future patients or patients who have been recently injured, you may find some of these practical and you may find some of these not very useful. I'll say that in the emergency department, there are specialists called child life specialists. They work extensively in several emergency departments that I'm aware of, including the emergency department where I work. And these are folks whose expertise is on helping those children prepare for and adapt to a potentially uncomfortable or even painful diagnostic or therapeutic procedure in the emergency department. And that's where some of the best evidence is for some of these techniques. Although, as I said, I do believe that there is an applicability in using these techniques for other patients. Many of these things are done actually before or during the procedure, and so depending on who you're caring for or you might be caring for, doing some of this as a preparation for the potential of being injured or exposed to pain or discomfort might be helpful. Things like relaxation training that can be done beforehand and then could be implemented by somebody who is injured. Distraction. Guided imagery, which I know has become somewhat popular in the preparation for other kinds of psychological trauma or for high stress scenarios, is something that can actually be used to help with reducing the pain, at least in instances of limited diagnostic or therapeutic procedures in a pediatric emergency department. And so I think that this is something that's worth considering and thinking about and how it might apply in your own environment. Speaking of distraction, there is some work being done, and some have tried to study using things like virtual reality as a distracting technique. Now, distraction, as I mentioned, is commonly used very successfully in pediatric emergency departments. And so there's a small study that was done in burn patients to try to determine whether these burn patients can actually have improved analgesia with virtual reality. It was shown to be feasible, but there was not an improvement in analgesia as compared to traditional distraction techniques. Nonetheless, this is something that might offer some potential benefit in the future depending on its implementation, especially as the quality of the virtual reality systems available continues to improve. Although again, this will not be feasible in many environments. And lastly, I'll talk about mindfulness and yoga. This patient population that was studied in the paper that I'm referring to here are sickle cell patients in vaso-occlusive crisis who historically have had extremely high doses of pain medicine required in order to treat their pain crises. So this study showed to see, is it feasible and acceptable to use things like mindfulness, video-guided mindfulness, breathing exercises, and yoga in order to help with these vaso-occlusive pain crises. And they did show that this was feasible and that it was acceptable to patients. The study was not really designed to see if it showed an improvement in pain or other things like that, but I think that this opens the door to other potential implementations in a patient population who has extremely high burden of pain. And so those are the topics that I wanted to cover today, and I hope that this is helpful to you in your practice. If any of you have any questions, or if there's anything else that I can do to answer your questions or help you, please don't hesitate to reach out. Thank you for your time.